Shireen. Shireen, can you record it?
It's
being recorded.
Yes.
Good.
So good morning to everybody. Good afternoon who is already there. I would suggest we wait one more minute. I don't know if there are more people joining, but just give them one more minute and then we get going. Okay, to give everybody participating enough time to present, I would like to start our webinar now. Good morning, good afternoon, good evening to everybody who is joining us today for our second open forum of the Joint Initiative Council. My name is Ulrike Kreiser, and I'm on the one hand side the Senior Vice President at GS1, a standard organization I think best known for the barcoding, and I'm responsible for healthcare there. But more important, I am the chair at the moment of the JIC, the Joint Initiative Council, a group of standard organizations who has come together to work together since a long time. And we are working together really, and this is one of the topics where our cooperation is making a lot of sense and is very valuable. And that's the topic we are discussing today, immunization. A topic which I think is close to all our hearts in the moment. It's important for governments, but I think it's a topic which is also very, very important to everybody of us in our professional version and life, of course, but also in our private life. It's something which I think is discussed around every family table regularly. But before I get into this topic and into the JIC, I want to give you a few hints on the logistics for our session today. So everybody is on mute besides the speakers, but of course we want you to have a voice, and we ask you therefore to post your questions in the Q&A possibilities of Zoom. And we also encourage you to show approval or not misapproval, to comment as you feel appropriate. There is the possibility, if you activate your mouse over the screen, you will have this little file button at which you can then pick the Q&A, and that's where you can write your question or your comment, and please feel free to do so. You can also encourage questions by using the thumb up, which you can see here on the screen, which then moves that question or comment up for the speakers. So I really encourage you, use this to be as interactive as possible. If we have time, we will also go into questions afterwards. And we have a lot of experts online, of course. We'll try to answer the questions already while they are coming in. One note here that our first speaker, Constantine from the European Commission, will need to leave before the end of the session. So questions for him need to be asked while or shortly after his presentation. And with that out of the way, let us get into the webinar. So what is the JIC, the Joint Initiative Council? It is not just another acronym in the world of healthcare, but it's an important group of standards organizations who already in 2008 came together to build really a collaboration between the different standard organizations to drive health informatics standards forward to digital transformation. And we talk so much today about the move to digital health, and standards are really the backbone of that. Because without standards and without the interoperability of the standards in healthcare use there, this will be a very difficult, lengthy, and complex work to be done. So we are committed to collaboration, and I can tell you only that in the time I've been part of this group, I have been really testimonying this great cooperation between all the people from across the world, but also from different organizations with our healthcare community worldwide. We want to ensure that health is really delivered in the best quality to everybody. And let's not forget, at the end, we are all patients, and it's really important. And I think never we have seen how important healthcare is than just in this time. So what is our mission? As I mentioned already, we want to promote interoperability. We want to avoid that there is inconsistency between our standards, and we feel that there's enough space for all of us, and that we need to ensure that we coordinate in the best possible way. But also we want to develop global awareness of the importance of health informatics standards. And this is, of course, one way of doing that. But I encourage you also to really have the possibilities to look at our website, to follow us on social media. We try to put out as much information to everybody as possible. And if you want to engage with us, feel free to approach us at any time. We also, as I said, share information already, and we promote what is done by the different standard organizations which are part of our group. because we know that we live in a time of information overflow, though it's important to point that out. Our core values, I think, are the ones which probably everybody on the phone is also having. Customer focus, really. We are facilitating discussions with our communities between each other. We are open and transparent, and I can only tell you that very open discussions are taking place in this group. We are looking at innovation, and I think the webinar today is talking about innovation because the vaccination, immunization, how do we capture that has never been so important, and today and a lot of development across the world is happening on that. And of course, we respect each other. These are the standard organizations which are part of the group. You see here CDISC, CEN, DICOM, GS1, HL7, IHE, ISO, LOINC, and Snomed. And behind these acronyms, these are the faces of some of the people who are part of this group, who are meeting regularly and are working together. And it's always, I think, important to see also the human faces behind the names. So what are we looking at today? What is the topic of today? Something everybody of us is in the moment going through in every country across the world as we are living through this pandemic. It is the vaccination journey of a person, and we have called this woman Adele. And we will go with you through the journey of Adele to vaccination recording. How will that be used when we start to move again, to travel again? How will we deal with the proof of either having been already having COVID-19, having a vaccination, having a PCR test? And you will hear in the morning about that, but also we have an afternoon session to accommodate other parts of the world better. So what are we talking about? We are talking about the 5C of digital health standards. We will talk about care guidelines, but also to the specifications which are related to the content, because we need to be precise if we want to digitally capture information. We will talk about coding, communication, and confidentiality. And we are thinking about kind of making this journey with Adele in different steps. We will talk about capturing data, and that's where GS1, LOINC, Snomed play an important role to document the vaccination process of Adele. We will talk about managed data. HL7, ISO, and CEN have important standards which are used to document then what has been given to Adele in the health records and in immunization files. Then it's of course important to share the data in a safe way, and CDISC, IHE, HL7 have really standards to document that in the very useful International Patient Safety Patient Summary, IPS. And that is something, by the way, which is not only important for vaccination, but it is something which is important for all of us as we are traveling and can get ill when we are in other countries. And then last not least, trust. ISO 10 HL7, along all these processes, we know that we need trust because we are talking about sensitive patient data, and we are talking about already seeing the first counterfeits of immunization passports, etc. So it's really important to have safe documentation. And all of this is, of course, playing a role then in the implementation. And this morning, we will hear the implementation of the EU, how it's happening in our part of the world. So we have great speakers today, and I'm very pleased that they all have been willing to really work on communicating what they are doing and joining us for some very early in the morning. So we will have first the European Commission speaking about the implementation. Then Jane Miller from Snomed will talk about capturing data. Giorgio Cantioli from HL7 will talk about managing data. Jose Costa Teixeira from IHG Pharmacy about the sharing, and Matthias Pox from CEN about the trust. So that's how the program looks for today. And as I said, please enjoy the presentation, but follow us also on Twitter and LinkedIn. Stay informed on what is happening in this space. And with that, we want to start the journey of Adele. And it's my big pleasure to welcome Konstantin Hyppönen, who is policy author of the European Reference Networks and Digital Health at DG Santé at the European Commission. And Konstantin, thank you so much for taking the time out of, I'm sure, your very busy days as you are working on the digital COVID certificate, which is in the moment really something which is discussed everywhere. Over to you.
Many thanks for the invite, Ulrike and the team, and happy to be here today, even though it's not a very early morning, it's 7 o'clock, so it's quite okay. So I will talk today about EU Digital COVID Certificate, which is being deployed as we speak, and let's move on. To start with, many of you have seen this colorful map, and of course, we're not very happy that the map is too colorful, but also it adds to the confusion of people because before the system, what we've seen is that different member states were requiring different types of documents, medical certificate, test results. There were specific language requirements. We saw people denied boarding because the certificate was not in the right language, or not of the right form, or not of the right validity, and so on. So this all is causing problems and confusion for people. So that's why we decided that we need to act. And we acted on March 17th with the proposal. And now what we have already in place is a pilot of the system. So 1st of June 2021. By the way, I hope you can see my slides. So on these dates, the system, EU Digital COVID Certificates, it went live with 7 countries. Today it's 9 countries already, and more are joining every week. So we expect even this week, some more, and next week, even more countries. In order to enable the interoperability between certificates issued by different member states, we launched the so-called EU Digital COVID Certificate Gateway. And the gateway does not pass through any personal data. It's only about sharing public keys needed for the verification of the certificates. Everything is pretty much regulated. So we have a regulation which is bound to enter into force on 1st of July. Yesterday, there were votes about the regulation in the European Parliament, and in about 2 hours' time, we should know the results of those votes. But 1st of July is set as the date for entry into force of this regulation. It's based on the article for free movement of EU citizens within the EU, and also there is a separate twin regulation, as we call it, to cover third country nationals who are legally residing in the EU. Because the legal basis is about free movement, other types of uses, such as access to restaurants or sport events or any other cultural events, they are not covered by the regulation. Of course, they could be covered by the national law, in which case we of course hope that a certificate issued by any country would be equally accepted in such a nation. And the certificates are vaccination certificates, test certificates, PCR or rapid antigen tests, and then certificates of recovery, which are based on PCR tests. So there must be a PCR event first to certify that the person had COVID-19, and then the certificate may be issued after that. In the regulation, there is also a possibility for amending the text later through delegated acts and enabling the issuance of certificates of recovery based on antigen tests and antibody tests. But now it's not the reality. So as I said, two different regulations. One is for EU citizens and their family members. Also, we have EEA nationals via incorporation into EEA agreement, meaning Norway, Liechtenstein, and Iceland. And in addition, it's also about Switzerland, which is then based on the Schengen acquis, and in that case, we could issue a Commission decision on the basis of reciprocity. The twin regulation is about nationals of third countries who have already entered the European Union, and I will talk a bit later about then third country nationals which are not staying in the EU, but for example, coming as tourists to the EU. What are the options for them? But how does it look like? It could look, for example, like this. It could be issued on a paper. So this is an example of a vaccination certificate on paper. It's we propose a foldable template, but the template is not normative. We've seen some countries going for this exact template, some countries modifying it. So even the paper is digital because on the paper there is a QR code containing certain information, and of course this QR code is even more prominent in the purely digital version, like on the mobile phone screen. And indeed, that is a digital proof for one of these three events: vaccination, test, or recovery. And then what goes into the barcode? The QR code. That has been specified by the experts in the eHealth network, semantic experts and technical experts. The barcode has been designed to be as small as possible because then it becomes more robust. But it's readable when printed also on not so high quality printouts. Maybe if you have a mobile phone with a broken screen, it should also work in more situations than if it would be a bigger one. And that's why the data is also very, very limited. So this very limited set of data is encoded, compressed, and then digitally signed. So the digital signature is also in the barcode. And then naturally, we need to have a system for verifying these digital signatures. So for that reason, there is the EU gateway established for sharing the verification keys, public keys. So three types of certificates, and let's concentrate on the information. So in the vaccination certificates, it's about identity, meaning personal data, name, and date of birth. Nothing more, no passport numbers, no identifiers, nothing else. Vaccine administered, meaning type of the vaccine, medicinal product, and some metadata. So, for example, which was the member state responsible for the administration of the vaccine, when it was happened, and yeah, some very technical metadata, such as the identifier of the certificate. For test certificate, again, very similar. So the same identity data, similar metadata, and then information about the test. So the type of the test, it's currently an AAT or rapid antigen test, which must be on a so-called EU list agreed by the Health Security Committee. Currently, it's 83 rapid antigen tests, but of course it could be bigger, that list. So for rapid antigen test, we basically includes the identifier of the test device, so that every verifier would be able to check if it's on the list or not. And then metadata describing what is, again, for example, the certificate identifier. For certificates of recovery, again, identity data, and then information about the past positive NAT tests, such as a PCR test. The certificate is issued as early as 11 days after the positive test, and it's valid up to 180 days. But of course, if the person is still in the hospital, we don't expect the certificate to be issued because it's a certificate of recovery. A very short description of what is the EU Digital COVID Certificate Gateway. Those of you who know how the public key cryptography is working, you know that it's based on key pairs. So one key is a private key, and the second one paired to that private key is the public key. So the private key is used for making the signature, and it always stays with the signer, with the issuer in this case. But then the public key is by name public, and it's needed in order to verify the digital signatures. So for that reason, we have established a so-called EU Digital COVID Certificate Gateway, DCC Gateway. So all countries connected to the gateway, they push their public keys. So it could be one public key per country, it could be 10 public keys per country, but it's not millions per country because we don't use public keys of individual health professionals here. And then all other countries are then fetching the keys and distributing them to their verifier apps. And then these are used for performing the verification of the signatures. Then the external connections are planned for connecting third countries. It's not only about EU member states or EEA member states, but also about third countries at a later stage. So the deployment roadmap has already happened. So we have published technical specifications, we have conducted tests, we have published 3 reference implementations for the wallet app, for the verification app, and for the certificate issuance components. And now we are in the process of onboarding the member states. So 9 member states have been onboarded already. Many have been tested already. And indeed, the EU gateway is already in production. You can find all guidelines and all technical specifications on the web pages of the eHealth network. There are many documents, and there you can check the way how do we code different data, what is the schema for the data, and also how the cryptography part is working. So then coming to this question of third countries and their nationals, for example, traveling to the EU as tourists, for example. First of all, an EU digital COVID certificate, it's not a travel document. We don't expect it to be always present. It's not like a passport, but in some situations it's helpful. For example, to avoid quarantines or to avoid additional testing. And if such a certificate is to be presented, so then a third country, they could issue their own certificates, and we could consider that that certificate is the system is equivalent to the one established in the EU. In which case, we would issue a so-called adequacy decision, stating that we have examined the system of the third country and we found it to be equivalent, and then those certificates should be accepted in the same way in the European Union. Before that is happening, there is a second way of doing the same thing, and it's about the conversion. So a third country national could arrive in the EU with their certificate, and then the member states could convert that certificate into an EU digital COVID certificate. But that is not a must provision in the law, it's a may provision. So some countries may decide to do it and some may decide not to do it. And for the adequacy decisions, we haven't yet issued a single one, so the process is not yet fully formalized, and we'll know how it works slightly better after performing the first adequacy decisions. So the next steps, we are working towards onboarding the rest of the member states and EEA countries, and working also with transport authorities, service providers to ensure the proper integration of the system. And then, of course, also working with third countries. And now that the system is in production, it's already about system support and change management. And at some point, there would be a sunset because the regulation is bound to end after 12 months after entry into force, unless prolonged by a separate act. But we are looking forward to that sunset as well at some point. So let me also speak just for half a minute about what happens after the sunset. Do we shut everything down? Are we calling this system nice, but staying in the past? Well, it will be in the past as the system after the sunset, but we hope that we would be able to reuse some elements of this system in other infrastructures, because while member states are building their capacities, their functionalities for EU DCC, at the same time they are enabling better health systems for vaccination, for test results, and so on. So we could reuse them in the My Health at EU, which is an EU-wide infrastructure, enabling the exchange of patient summaries and e-prescriptions at the moment, but later also other data. And that data of the patient summaries, they include vaccination data. So it's already a good, it's already a benefit for My Health at EU. Then last week, the Commission proposed a revision of the eIDAS regulation. It's about eIDs, and there we could see, if that proposal is adopted, an EU-wide digital wallet app. So we could see this or similar certificates living later on in such a digital wallet app. And one of the cards in the app could be an EU vaccination card, for which we're running a feasibility study, and then the decisions on the possible deployment would be taken later. But again, while building EU DCC, we are improving health systems across the European Union, and not only in the EU. And for example, we expect that vaccination data and test data would be of higher quality after this exercise. I will stop here. Thanks a lot, and I can answer any questions if you have some.
Thank you so much, Konstantin. That was a great overview, really. And yeah, you can see that you have thought it through. There's one question of Andreas Klingler here. How is the use of the certificate outside of Europe envisioned? And what is the relation compatibility to the WHO initiative? So you talked about you recognizing certificates of other countries, but do you think that the EU one will be also acknowledged in others, and do you work with WHO?
Yeah. So the recognition of EU digital COVID certificates in third countries, it's not covered by the regulation, by the way. So that's why I cannot really comment on that point. Of course, we hope that they would be recognized, and we've seen that countries approaching us, they are interested in both types. So maybe because they want to see European tourists, or maybe because they're simply willing to do so, but it's not covered by the regulation. So it's our only hope that that would happen. And of course, we are explaining how to verify and so on. So we are supporting this. Then for the EU initiative, yes, we have worked together, but maybe you noticed, was it last week or this beginning of this week, that the WHO has modified their plans. So for example, they are no longer planning to establish a public key directory at the global level. And they are concentrating more on the digital documentation of vaccination events and other events related to COVID-19. But yes, we have exchanged many thoughts, and also we are exchanging information, for example, on how to code vaccines, and that is still an open question because there is not a global registry for vaccines still.
Yeah, exactly, and the world is very global today. And I think this can be a great push into going more into really have global vaccination passports instead of the little yellow one. There's one other question to you, and which I think you have already touched a little bit on, coming from the Asia Pacific room. Is it allowed if no EU countries would like to adopt or join this architecture? Would you be willing to share, or is this protected? Is this IP protected? I don't know.
So all the specifications, they're openly available. Feel free to use them. We have also provided reference implementations, which are open source, so feel free to use them. We welcome any use because that's also helpful for us. And as I said already, if a third country wishes to join the system, it's also possible. And for that reason, there is a mechanism called Adequacy Decisions. So we have to analyze the system of the third country. And if we find it to be interoperable, equivalent to our system, in that case, we can issue such an adequacy decision. And of course, if the third country has directly applied our specifications, for us, it would be much easier to issue such an adequacy decision.
Great. There are no more questions, Konstantin, and thank you so very much, really, for taking the time to talk to everybody about this. It's, I think, super important, the work which you are doing, and really appreciate that you could join us today. Good luck in moving forward, and let's hope that we can sunset this work sometimes and move forward in a more normal world again. Thank you so much, and all the best for you. And of course, stay as long as you can, but I know that you have to go at some moment in time. Thank you.
Thanks a lot.
And with that, I hand over to our next speaker, who will start to talk about the capture part of the journey of Adele. And that is my colleague, Jane Miller from Snomed International. Jane, I hand over to you and allow you to share your screen.
Thank you. Let me put that up. And if you could confirm, yep. Okay, good morning and good afternoon and evening, depending on where you are in the world. Yes, I'd like to talk about the capturing of information that actually is maybe used to identify and code vaccine information and the whole card side of it as well. I'm going to cover three areas of standards, three standards: Snomed Ct, LOINC, and GS1 standards. Those three organisations are all members of the JIC. I'm going to touch firstly on give a little bit of an outline for those who don't know the three standards, just so that I can orientate you. And starting off with LOINC, which is the logical observation identifiers, names and codes. And LOINC is a global standard for identifying health measures, observations and documents, and was established initially by Dr. Clem MacDonald in the US. He was an investigator at Reagan Street Institute at the time. And really, he was responding to a need for universal language for observations for the electronic data exchange for clinical care, focusing on labs, offices, hospitals, and payers. And over time, it has increased in both the content and its scope. And really, the key thing is it was set out to be this universal language for observations, for electronic data exchange, so that laboratories and other entities could communicate orders and results to hospitals, providers, and physician offices. And in doing so, today, that includes both laboratory, clinical order, and result concepts, and is approximating 100,000 codes now, and it's maintained by the LOINC Health and Data Standards Program at Reagan Street Institute. And we do have representative from Reagan Street Institute on the call with us today, which is great, the CEO. So moving on then, talking about LOINC to capture immunity data, which is obviously the topic of today. There is an array of content in LOINC that exists to support a number of use cases, including ordering tests and observations, collecting information, and generating and reporting results. And together, these pieces of content are important in describing the facets of the clinical process that are necessary to paint the clinical picture as it moves through the interoperability continuum. For the purpose of today's discussion, we'll focus on three main categories of content or domains for LOINC. The laboratory LOINC, which you can see here on the left, which includes laboratory tests, whether they're performed in a hospital or in an outpatient setting, in the provider office or the public health facility, or by the patient at home. And that obviously with COVID has become increasingly more so. Clinical LOINC, in the middle one here, it includes all types of measurements, procedures and documents and other clinical information not found in the laboratory domain, more specifically anthropomorphic measurements like BMI, eye color, and a head circumference. It's a bit early in the morning, apologies. And procedures like EKG, cardiology, and ultrasound. And there is the standardized surveys, instruments, and documents section, which actually are part of the clinical domain of LOINC, but are worth calling out separately here. I think so that people are aware. These areas include things like patient-reported outcomes and patient-reported outcome measures. And this area also includes assessments that the provider completes and other things like forms such as those required by the local and federal governments. And I think the reason why we've covered all of these areas, because these we talked earlier about the use case, and I'll come back to that. But this is about collecting the data initially and then flowing through the system and being reused. Moving on then, a little bit further, we've got a drilling down a bit. Laboratory LOINC has laboratory tests such as those to perform an assessment of antibody titers. Examples for LOINC, clinical LOINC, include terms to describe an immunization series, such as the number of doses in the series or the actual dose number itself. Clinical LOINC also has content to describe details about the patient, such as the age, etc. Now, in many countries, those use ISO standards, and I think it's worth mentioning that. And if you think about country codes from ISO, the demographics would be used. The demographic data would be used using ISO standards. And that's the whole point is, and we'll come to this, is we're emphasizing that there is choice, and we're only offering here some of the options that are actually available. Examples from clinical LOINC include terms to describe an immunization series, such as the number of doses in the series or the actual dose number itself. Clinical LOINC also has content to describe details on that. And then the survey section of LOINC includes administrative terms that might be found on a form to help identify a patient or convey the name of the caregiver. Moving on then, I saw that actually somebody's asked about analytics in the questions. LOINC does have a concept model, and that is the key part of LOINC that facilitates the exchange of data electronically when data is encoded with LOINC, and therefore enables that flow. And you'll see when we talk about Snomed, it's exactly the same. And this is critical to, there's no point in just collecting that information. It's about then reusing it and moving it around. And the concept also facilitates data exchange in the manner where the semantics, and that's the key thing, or the meaning of the data, is preserved, so that all of the information can be reprocessed and reused. So if we then go across then to, I want to talk a little bit more about that. Hospitals A, B, C, D, and E in this diagram we have examples here. Display the measurement of systolic blood pressure differently, however, because they each standardize and exchange that information using the LOINC code 84806. The meaning is preserved. So the functionality imported by the LOINC concept model is critical. Comparing and analyzing data, for example, when these data are pulled together and analyzed across national norms. And just to reiterate, this really is about analytics functionality. Moving on further, talking about the capturing of immunity data with LOINC, and talking about linking back to what Konstantin has said. LOINC has collected a full set of COVID-related content, including content related to vaccines and vaccinations, in one place for the convenience and ease of browsing. And you can see a link here to actually looking at that data. So that is the key, is both the content and the guidance on the use of that content as we go forward into capturing the information and reusing it, not just in relation to the patient, but also secondary uses and analytics. Moving on to Snomed Ct. Snomed International owns and maintains Snomed Ct, a global clinical terminology used in electronic health record systems, as many of you will know. Encoding health information with standards such as Snomed Ct is critical for frontline service delivery, pandemic surveillance, and retrospective data analysis. And Snomed Ct supports the representation of detailed clinical information such as patient illness, vaccine administered, and more. Focusing down to today on the whole immunization side of things. And just as with LOINC, it's underpinned with a logical model which provides the fundamental structure of Snomed Ct, specifies how the components can be managed in an implementation setting to meet a variety of primary and secondary uses, such as that data retrieval analytics. It's really about making sure, as with LOINC, that actually it's got that structure that people can adopt so that systematically you can retrieve information and it remains exactly the same and it can be reused. Going on now to the immunity data, Snomed Ct can be used to capture the indications for medication vaccination prescribed, the medication, the vaccinations themselves, the dosage, the routes of administration, and the target sites. And so it's linked, and I think if we refer back to Europe, as was spoken about it with by our first speaker, with Snomed's also got linkage to other standards that are used in Europe. So that will enable the free flow of the data. Snomed International is committed to ensuring alignment of in-scope Snomed Ct content for both the European work on the certification and the WHO work on certification. Now, at the moment, as we've just as we know, the names of these products and the projects are changing, and the scope of these projects are changing as more knowledge and information emerges. So one name might be right today, and it was when we put these slides together. And we know that today, for example, the WHO certificate is actually being renamed and rescoped. But Snomed Ct COVID-related content is available. It's published currently, and both the current release from January 2021 and pre-published for the content which is going to be in the July release, which comes out at the end of 31st of July. Includes an update to the Snomed Ct to ICD-10 map for COVID-related terms. Obviously, this relates to indications and problems, and including the Snomed Ct equivalent terms for what is being worked on by the WHO in the Smart Vaccination Certificate, or its new name. And we are putting all of this content into the Snomed Global Patient Set so that will enable exchange whether you are a member or a non-member of Snomed Ct, of Snomed International. A little bit more about that Global Patient Set. And I think that it's very valid to talk about this because we released in 2019 the Global Patient Set for the first time to enable the sharing of patient health information coded with Snomed Ct without needing a full Snomed Ct license. This is freely available via the Creative Commons Attribution version 4 international license. And it really has been in response to what's already been referenced by Ulrike and by Konstantin, both the International Patient Summary and the certification to enable the movement between countries. And this isn't just about Europe, this is about movement between member and non-member countries in the Asia-Pac region and also in the Americas. So at the moment, it includes all of our reference sets, some of them clinical, the specific like dentistry, the International Patient Summary, which is used in HL7 standards, and we're also covering the standard that has been released in Europe and ISO. Then general practice content, renal content, nursing content, DICOM, IHE, social determinants of health, and obviously the COVID content. And this is in freeset format and also in RF2 format to enable sharing, which is, that's the Snomed release format. And it includes concept identifier, the fully specified name, the preferred term, and its status of whether it's active or inactive. And we will be including the latest information related to both of the initiatives in Europe and WHO in the next release of the Global Patient Set, which will be at the end of August, beginning of September, based on the July release of Snomed. So that's touching on Snomed and Loink, which are both used. They're used in relation to clinical information globally in different parts of the world. And I just want to touch now on GS1, which is a global standards organization, has over 2 million companies worldwide use GS1 standards. And in 150 countries, we've got 25 industries served within 150 countries. And I saw this figure and I'm thinking, oh my goodness, 6 billion barcodes scanned daily. This is just amazing. And 114 member organizations around the world. So, as all of you will know, GS1 isn't just in health, it's right across the platform. So has got very, very wide experience in this area. Then just a little bit wider, and my thanks to Marjorie from Loink and her contributions here with this is, we've got other standards, for example, which are used quite widely in the vocabulary area, Unicom, and medicinal product dictionaries, as well as LOINC and Snomed Ct. And then, particularly in the US, for administrative codes, they're using ICD-10-CM, and also you've got the procedure codes related to CPT. And as I mentioned earlier, ISO standards are used as part of the records to support the administrators, the demographic information about a patient, and that's what will be will be flowing into any forms of certification. But we need to make sure they're standardized initially in the clinical record, which is what we're talking about here. And then for the supply chain end, the product identification from the GS1 data matrix, we've got the GTIN, the global trade item number, and we've got the lot numbers coming in through that route. And my thanks to Christian for this slide. Christian is on the call and can discuss any GS1 specific questions. As we know, the immunization requires unique identification, which we do not have globally at this point in time. And I think we're all working towards that. But by scanning the GS1 barcode, the system is documented. I mean, here you can see in each of the regions, we've got different brand names and different ADM dose forms actually being described. But if you're getting standardization where the system is documented with GTINs and the lot and the batch number, that is absolutely key. So if you take a modified version of Comirnaty, I should have asked Christian how to Comirnaty, how to pronounce that, will be marketed to address a virus variant. The brand name may remain the same, but the GTIN will change if it's branded to address a variant. So I want to just touch on what's already been said, the narrative related to Adele. Adele Bakker is 48 years old and immune suppressed because of a prior kidney transplant. This places her in the phase 1 priority group for receiving COVID-19 vaccine. Adele is contacted via email by her public health authority and scheduled to receive dose 1 of the mRNA vaccine approved by a country's Ministry of Health. She presents at the clinic at the scheduled time. Her identity is established, she is assessed, and she receives the dose from nurse Charlie Delta. The details of the vaccine administration are recorded in the clinic's local EMR and updated to a shared electronic records repository. So already data is moving. Adele receives a printout of the details of her dose administration and an account, and an appointment is scheduled for her to return for dose 2. And here in this, I just want to actually show you which parts of the record of this use case, this isn't the record, this is the use case, can actually be picked up using the LOINC codes. And I think, and then I just want to go back to that one. And you'll see here, age, for example, so that's over in the demographic, the immunization measurements, using the surveys and documents parts of LOINC, clinical LOINC, and again, the administration side. So we're covering quite a bit of it. Moving on then with Snomed Ct, we've got exactly the same use case as we talked about, and the different parts of that use case which would be captured within the clinical record. And again, you're going across the different parts of Snomed. We're looking at situations, the clinical observations, areas of Snomed, the findings, the medicinal product area and the procedures area, and down as far as the environment when we're talking about the clinics. And I think that we've put in here again, referring back to the question we've already seen about analytics. This is about identifying the cohorts so that they can be so that we can go into the analytics side of things. And moving on, this is the GS1 side, picking up the GS1 global location number with the clinic, and the global trade item number, the GTIN, and the lot and the batch number, so that we've actually got details of the vaccine administration. So this is a very messy slide, but I think it just shows you that in some areas you will find people who the policies and things will actually be using just one terminology, and also then obviously the GTIN and the barcode information, and then for others they're using mixtures of terminologies, which is why, you know, it's good to be speaking here and giving you two examples of terminologies which are used with Snomed and Loink, both of whom are members of the JIC. And in summary, what I want to say is that terminology and supply chain standards are determined by country-specific digital health policies, and the use of the GS1 standards will depend on that, again, on that country digital health policy. Terminology standards do not work on their own. They're part of the interoperability solution and have to coordinate with other standards areas, such as HL7 and IHE, both of whom are members of of the JIC, and we all work very closely together, and we all interoperate with WHO classifications, which are obviously needed for secondary uses, analytics, research, and public health. This use case, I think, illustrates what already exists in these terminologies and with the work with GS1, and can be captured in electronic health records at this time in relation to vaccination and immunity data. As we've already said, the terminology is currently being defined for both the EU work and the WHO work, and in the US for the work of CDC, which actually obviously impacts a lot on the rest of us, because they're one of the major disease control and prevention centres in the world and interoperates with others. So that's another facilitator that we need to be working with. And there I am. Thank you very much, everybody. I'm speaking on behalf of Marjorie and Christian, and I speak here today.
Thank you very much, Jane. And we have Marjorie also on the call, despite the time for her. So thanks a lot for explaining the capture part. And without further ado, we go to Giorgio Congioli from HL7, who will talk about the manage part. Giorgio, over to you.
Thank you so much. Good morning. I hope that you are able to see my screen. Okay, yes. So let's see. Okay, great. I mean, that this session, as you mentioned, we try to describe how the data that are captured can be consistently represented during the vaccination journey. So, but trying to address this consistency, I think means to face a set of different challenges, like answer questions like what are the information that need to be captured, how to provide the context for this data that is captured, and how to assure that there is a consistent representation of this data in order that can be also reused across the different steps or within the different domain. The answer for that is to have an harmonized ecosystem of cooperating standard and solution. And that means to deal with a set of different layer and profile product standard that try to address the above mentioned challenges, so that they can assure that we have, for example, a core set of information that can be understood and recognized across the different steps of the journey, and that can be smoothly shared in these different steps. For example, how to represent or identify or classify a product. Layer mean that you may to provide an implementation independent description of the data elements that are to be shared, providing the context in which the data are captured, and reducing as possible the ambiguity on the information that are shared. For example, I mentioned a real case. If I'm referring to the administering center about immunization, is that the location where the vaccination happened, or is the organization that is responsible for the vaccination? So clarifying these ambiguities help to better understand and better share the information and to represent them. And this might be the role, for example, of the ISO TS 5384 that I will talk about later on. So obviously, the expectation in that sense is not to provide a model of the entire world, but to at least agree on a set of core set of data that, as I told, can be consistently shared for supporting the immunization workflow. There are then other products in this ecosystem that provide rule on how to let's say, realize how to implement common component. The first one might be, for example, the base HL75 standard, but also the International Patient Summary FHIR specification, up to arriving to more specialized implementable profile that describe how to use this standard or this profile or this implementation guide in specific jurisdiction, use case, or for specific scope, like, for example, the FHIR Vaccination Certificate initiative, and so on. Up to arriving to other artifacts, like the QR serialization that might be used for proving that the vaccination happened. So, what is the role of this implementation independent model? One role, as described before, is to provide the context that is required for capturing in order that there is a clear understanding of the clinical side and on the technical side on how data can be used and understood. And the implementation independent model provides also a common understanding of the data that are required, reducing, as I told, the ambiguities that are no more left to the implementer to try to resolve them. I mentioned the administrative center, but another example that we recognize is, for example, about the manufacturer. With that term, sometimes are intended different roles, like the real manufacturer or the marketing authorization holder. It is important that these roles are well specified, and hopefully they could be derived from the IDMP definition of that role. So let's move to one of the components of this possible ecosystem, the International Patient Summary. As you probably know, this is the result of a cross-SDO collaboration. It is designed for cross-border and multi-languages. It is open for IDMP support. It takes advantage, as mentioned by Snomed Global Patient Set. And it describes a global minimal data set that might be reusable beyond the specific jurisdiction and domain. And it provides also implementable specification for the data set in FHIR and CDA. And these, let's say, components are recognized to be useful beyond the emergency case. That was the initial scope for which the International Patient Summary was designed, but it's growing and growing the interest on reusing this component beyond this scope as a common baseline for building other kind of document. As I mentioned other time, this is a slide that was prepared several years ago that identify what is the current trend of reusing some of these components to, for example, define a possible immunization certificate. The interesting thing is that as we have seen, the certificates are no more limited to the vaccination event, but take into account also other information like the test result or the condition if a recovery happened. And this information can be as well represented by reusing other components that the International Patient Summary made available. Moving to the 5384, the 5384 provide a set of immunization data element by use case, so that they can identify what are the description, the requirement for fulfilling specific use case. And it aims to align with other initiatives like APS, IDMP, and so on, and to facilitate also a consistent implementation. This providing also a physiological model representation of this data set. The physiological model is still an implementation independent model, and suggesting mapping to selected specification, in particular HL7 fire. But let's see how this may apply to the adult vaccination journey. Let's start, for example, on the record of a current implementation. The ISO 5384 provide what is the data set that are expected to be used for recording a current immunization. And this data set is obtained as a refinement of a general model that is shared across different possible use case, providing a common reference for the immunization data. This general model is consistent with the ISO and SAN IPS dataset, and it uses some of this component, for example, for the patient or the provider description. And as mentioned, that model, with that model is also provided a mapping to HL7 fire to suggest how this model might be represented. As mentioned, the IPS provide also not only an implementation independent model, but also provide rule for implementing the IPS in FHIR and CDA. So the FHIR IPS that implement this model provide a common baseline across different domains, providing a set of building blocks that can be reused, with the advantage that a possible FHIR profile that would like to record a current immunization, that it is derived from that model and it is compliant with the model defined by TS 5384, guarantee or assure a set of consistency so that the information that you have when you send the record of a current immunization, you can be sure that this information can be reused, for example, for generating an updated IPS. And this is the description on how in reusing this set of related standard that you can assure that the data that are captured during the immunization can be consistently recorded into a registry and, as I told, reused, for example, for updating International Patient Summary with immunization data, or even for other scope. So that if we're using the IPS standard, I can suppose that these information that are captured can be this component reused for creating a FHIR vaccination certificate, if you would like to do so, or enhancing the IPS, including the immunization information with the required data, so that this document can be used through appropriate transformation to generate, for example, digital certificate as mentioned before. So to conclude, all that to say that if we would like to assure a consistent representation of the information across the adult journey, and possibly also beyond this, we hope that we can continue on working on this ecosystem of standard based on IPS and 5384, hoping that could be enforce the relationship between the different artifacts that are produced or should be produced for fulfilling specific use case in specific jurisdictions, so that we can have a model that might be derived from the model offered by the 5384, and with a specification that implementing this model, reusing as possible the IPS component, so that independently on the so that these different implementation could share a common set of data and can share consistent information referring to the same data in a not ambiguous way, and from that derive other artifacts like the QR code that might be used for verifying that a vaccination happened. You can trust in that. So thank you so much, and I will give the floor back.
Thank you very much, Giorgio, for showing really the picture how things are coming together and how the different standards are playing a role there. Thank you. Without further ado, I hand over to Jose Costa Texera from IHG. Jose, the floor is yours, and if you start sharing your screen when Giorgio has stopped.
Thank you very much. Good morning, everyone. Let's look at this from the data exchange perspective. Let me share my screen. The data, sorry, I don't know if you can see my screen yet.
Not yet, we see you still.
Okay. I hope you can see it now.
It's starting. Now, you're there.
Yeah. So again, good morning, everyone. Thanks for the opportunity. Thanks for the very good introduction so far. We're going to have a very brief discussion now about the way to exchange this data. So taking everything that we have, the other presentation, so from the management of data, from the data structures and concepts, from terminologies like Snomed, putting this all together in a way that we can exchange. So going back to what Ulrike started the session with the 5 C's of digital health standards, a few points about each of those 5 C's. So the care guidelines. In terms of exchange, if we exchange data, this means that context really matters. So if you're exchanging data about patients' vaccination, it really matters if you're talking about this, the vaccination for a patient that has already had COVID or not, because in some cases this might differ, or the guidelines might differ. So if the guidelines differ, the data that you might need to exchange or data that you might need to capture even, those might be different. So the care guidelines is kind of the envelope, or the kind of the context, or determine the context for data exchange. And that is really important, because as we'll see later, it really influences what the data means and what are we talking about. And if we don't know what we are talking about, exchanging data becomes a bit more difficult, or much more difficult. The content specifications, that is what we are used to see in every specification. So when we look at standards, or when you say this is an exchange standard, most likely or most commonly, what we are looking at is the content specifications, is the structure of the data, is the meaning of the data as well, is the how many names does the patient have, is the barcode or the identifier in the barcode mandatory, is the gender of the patient mandatory, etc. So those are the content specifications that we have to do technically. But as Giorgio was just pointing at, if we do it technically, we also should look at the the logical and conceptual definitions of those data so that it is consistent. And one very clear case of this need for consistency is exactly the international nature of the vaccination certificate. If the patient has a journey for vaccination, but that's just the beginning of the journey, then the patient will get the vaccination certificate, the card, and that certificate will be used not only in the country where the person was vaccinated with a given context within given care guidelines, but the patient will also be using that in other countries. And the patient expects, so Adele will expect that this is valid wherever she visits, even if the guidelines are slightly different. So next to this, when we do standards, we see not only what the data is about and what's the content of the data, but again, also coding specifications. So if we have common terminologies like Snomed, like LOINC, like others, we can see that data will become interoperable. If we just have this on a national scope, on a local scope, it becomes a bit more difficult, or much more difficult, which means that this data should be up to date. So if there is some data that needs to be synchronized, so the subset of Snomed, sorry, that Jane Miller was just was presenting, this part that is freely available. If this part needs to be used in different countries, then it must be also itself exchanged across countries. So all the countries have to have the data. So what we are talking about is several mechanisms of exchange of data. We're talking about the data about the vaccination, but also the data that is needed for the systems to provide that functionality. And next to this, we just have the technical specifications, so technical platform specifications, so communication specifications. This will be the envelope, more architectural things like, do we use a push or pull model? So these are more on the technical level. They are extremely important to set up a platform, because if one system sends the file by email and the other one expects it by FTP, sorry for the comparison, then we have an interoperability problem, an unnecessary interoperability problem. So that's the lowest level. And across all this, and this is very important, is the matter of confidentiality. The consent of the patient and the rules management. So sometimes the patient has to give consent, sometimes the patient does not have to give consent. The encryption of the data, the authentication to see that only trusted people can see the data. And when they see it, is that data really what it was meant to be? Is that data correctly signed? Can I read the signature? So those confidentiality specifications, they are also extremely important. Normally, when we talk about confidentiality in this level, we talk about confidentiality about privacy, but it could also be about protecting intellectual property of someone. So if we have some other requirements to say this information cannot be available, not because of privacy, but because it is paid information or because it is protected information somehow, this also needs to be included. So looking at all this and looking at the journey of Adele, so what we have taken from the Digital Green Certificate from the European Union or from the European Commission, we have we took the Adele journey and we transformed it, or we transported it to how does the interoperability mechanisms, how does the exchange work for this journey. So this is just to give you a brief overview of what happens here. When the patient, the first step is that the patient identity needs to be confirmed. And this is important during the scheduling of the vaccine. So for example, when we say that this person at this date can have the vaccine, and then during the administration itself. So the identity of the patient needs to be confirmed in at least those two steps. And that is important already to see the relevance of the care guidelines. It really matters when do you schedule this. So as long as the patient enters the system will say, is this patient who they say they are? Does this patient have the right age or the right conditions to be vaccinated now, or is it in another vaccination slot? So this matters for the patient. Another example is the protocol. So does this patient get this vaccine or that vaccine, depending on their conditions? Does the patient get 1 shot or 2 shots? So this will be there. The guidelines will be there involving the exchange or the need to exchange. The content definition, this will be the usual questions that we are all used to, at least I am. what data do we need to share? So we need to share enough data for the patient to be identified. What is that? We need to share everything, or is just one ID? And if it's one ID, does the other party recognize that ID? Is it the passport number? Is it the national number? So what data do we need to share? And are those data sets consistent and reusable? So is that data a reusable concept? So going back to what Giorgio was presenting before, and going a bit into the role of CDISC, if we say that this data means this, then it's more likely that everyone across the journey of Adele will have the same understanding of the data. And this is very important, to define the information and then apply it technically. Then we have the technical matter of how is it coded, so what are the terminologies to use, etc. In the case of the patient identification, this is somewhat trivial, I would say. The communication is just technical mechanisms, as I said. Is it a REST? Is it a push or a pull? Is it a document? So these are more technical envelope things. Then the vaccine is administered. So there we don't expect much interoperability or exchange needs, because it's just one nurse giving the data, except the interesting case that when the nurse, or the interesting need that when the nurse is doing that, at that moment or shortly before, the nurse is capturing with a barcode, hopefully with a barcode, the lot number and the expiration date of the vaccine. And that information, so the meaning of lot number and the expiration date, that is clear. So in terms of content, that is clearly defined by GS1. The coding is also clearly defined by GS1, but it is, again, one part of the mechanism, of the communication mechanisms that we have to have. So when the nurse captures that, where is that information going? How does it get stored? So then that after the vaccination is happening, and all the follow-up, like for checking secondary effects, etc. We have the vaccination needs to be stored. So the nurse, or the one that is administering the medication, they will say, this patient has been vaccinated against COVID with this vaccine, with this lot number, with this expiration date. So this is the starting point for the real data set that we have explored. So, and here as above, the content, so what is shared, so all these data elements, the coding of that, which standards to use, do we use Snomed, do we use other codes for the product, how do we match the JIC, which is the code of the product, with the Snomed, that means the vaccine or the disease for which the patient is vaccinated, or the type of vaccine. Is it a messenger RNA, or is it another type of vaccine? So all this information is present as of this moment. When this happens, this is the end of the first part of the journey. And a few points is that the content has already been kind of defined. So as Giorgio was mentioning, we have the IPS as a base standard. So when the nurse says, or when the institution says, this is the registration of this patient's vaccination event, this could be an IPS. Or it could be, or when we want to issue that data for creating the certificate, it could also be the IPS, but more likely it will be a subset of IPS. Why? Because of this firewall here, which means that sometimes for the nurse, for the internal matters of the vaccination center, we need maybe a lot more information than what we need to express the certificate. And that is very important also because of data protection reasons. We don't want to share everything with everyone if we don't need that. So that's a data minimization procedure. So we could use a subset of IPS because the issuing service might be outside of our trust zone. And in that sense, it is the same approach. So how do we issue the certificate and how do we consult the certificate? We have the same concerns. So we look at what is the core data set. And in this case, it must be international. For example, if I learned recently that if a patient has had an infection of COVID in some countries, they will just get one COVID vaccine shot. In other countries, they will still have both shots to be fully vaccinated. This really matters, and this core data set must support that variation, because if it doesn't, then we don't know, or the receiving party does not know if the patient is fully vaccinated or not. So this content is really key, and it comes a bit with guidelines, with the care guidelines that apply to each country. So the content must be truly international. Of course, the coding is international, because if we say this is the product code in one country, and if the other country does not recognize it, then it's really impossible to see if this person is fully validated or fully vaccinated, because we don't know if it's a one-shot vaccine or a two-shot vaccine. The rest is just the technical implementation of this. I'm kind of lowering the expectations on that, because that's exactly what IHE does. So IHE is a group that takes care of the content and the coding that are provided by other standards and putting those in the right technical mechanisms. Technical mechanisms are really standardized today, so there's not much magic into that. There's work, but not much magic. The key part, and to align with the other speakers, is to make sure that the data is consistent and trusted. So again, on the if we need to do the offline verification of the certificate, then we need to have a public key infrastructure to define the trust of, or to establish the trust between the entity that has a certificate and the one that's going to validate it. And there we have the matters of confidentiality. Can I trust this? Has this been changed or altered in some form or not? Can I trust that party that is issued that? So this is, if we have this kind of verification, we need that information to be there. And all of that transports us back to what data is in the certificate. And that's why Konstantin was, or that's the consequence of that is what Konstantin was saying, that we have a signature inside the QR code, because if we don't have the signature, we don't know if we can trust that information. For online, it's also the online verification is also possible for the certificate. It is the same thing, except that we just do it online. We just check the service on. We just use an online service to check that. So to show now as kind of a wrap up how this works with the different standards that we have mentioned, that we have been mentioning this in this session. So this is the journey, this is what happens. So we've seen that we have to define the data, what it means, we have to then specify it in an implementable way. This is kind of the map of where the standards play a role. So IPS, as Giorgio said, has defined a logical model. Sen and ISO have defined that model. Then IHE makes implementable models, HL7, CDA, those are implementable specifications, and LOINC and Snomed, those are implementable. Of course, they are actual codes for products, for conditions, for situations of the patient, for types of location, all of those things that play a role there, they are standardized terminologies. So putting those together in an international or internationally compatible format, that's the implementable model that we have for IPS. And here we see the difference between the logical part and the implementable part that Giorgio was mentioning. And this results in our vaccination certificate, which has all of these, and also the essential ingredients that put this information together. So CDISC issues standard concept definitions. So it's important to have our definitions in the right place or in the right sense, so that we don't reinvent definitions that will then be difficult, for example, for analytics. If we want to do analytics only on vaccination certificates, that's fine. But most likely we want to exchange that data in a way that it can be analyzed. This COVID vaccination can be analyzed next to other vaccines or next to other diseases or next to other conditions like pulmonary insufficiencies, etc. So these standards, they come together with CDISC providing a bit of a conceptual or ontological overview or base for this. And then, so GS1, as I mentioned, as information exchange and data capture standard. And then the European Commission from the European Union and the WHO providing the surroundings or the international surroundings of this, which are essential because that is what limits our scope. That's what defines how international and how robust this has to be. Online and offline, papers first, etc. All those questions that have been answered by the implementations, they come from there. So this is it. I don't know if we have questions open.
Thank you, Jose. I think we can answer in the moment online. I would love to move to the last presentation and ask our audience for a little bit of patience. I know we are a little bit late, but I would like to cover also the trust. And Matthias from Sen will talk about that. Thank you, Jose. Matthias, over to you.
Thank you very much, Ulrike. Let me just share my window.
Yeah, we'll see if you can stop. Yes, thank you.
Right. I'm gonna be brief. I have 2 slides presented here. We're talking about today the toolbox for the infrastructure of immunization data. And I'm delighted to be able to present you the trust part of it. So these 2 slides aim to highlight how standards can be used to create confidence that the right metadata is used. And also that the benefit of using technical standards is recognized, and in particular, the collaboration amongst the standards development organizations is key. So on this slide, you see that at least 2 standards development organizations had to collaborate to come up with the standards here. In this case, it's ISO and HL7. But one you don't see here is the one I'm from, which is CEN, the European Committee for Standardization. So in the domain of authenticity, validity, provenance, or in other words, identity and security. But let me also add a third very important element, which is privacy. You can see that there are many standards. Let me just highlight a few of them. One of them is 21089, which is about the end-to-end trust paradigm. Another one, the ISO HL7 10781, is dealing with the EHR system functional model. There was a release 6 years ago, and this document is maintained by HL7, which released an update last year. And a third standard I would like to highlight is from the HL7 FHIR domain, treating the record lifecycle event implementation guide, which is part of the release 4 core. And you can find more information online about this standard. I just wanted to also draw your attention to the fact that when we talk about the toolbox for the infrastructure of immunization data, we are, of course, in a domain where other standards play a role as well, and they are complemented by these standards. There are standards that are important for this particular use case that is of interest to our session today. Record identifiers, QR codes, barcodes, standards from ISO, for example, World Wide Web consortiums, verifiable credentials, concise binary object representation standards on signing and cryptography. And for this particular use case also, of course, because we're talking about free movement across countries, the ICAO public key directory, just to name a few examples of standards that coexist with the ones from the health informatics domain. But it also needs to coexist with legislation, policymaking, and regulation. Trust is about identity and security, but also, as I said previously, about privacy, what we call in Europe data protection, data minimization, privacy by design. The fact that you have EHR records and they and there are limits to it, and unlinkability is a technical constraint, which should also be supported by technical standards. The other thing that policymakers, such as now the latest developments by the Covet certificate, is that policymakers also specify technical interoperability. And they're wise to do that by referring to technical standards, and they do so. For example, you can see that in the EU, you have the eHealth Network, which is a group of national ministries of health, and they publish documents on the interoperability of the health certificates. And they have a specific specification also on the topic of the trust framework. So the one that is now of relevance to this particular presentation. Now, these are the standards that are useful and the benefit is recognized worldwide. And what about Adele's story? As you can see, the narrative that we have for Adele and in her journey is not, there's not one step that is particularly related to one to the issue of trust. It's the identity, security, and privacy topics are related to each one of the steps in the journey. So starting with the time when Adele presents herself at the clinic, where her identity has to be authenticated. Going to the vaccine administration, when the entries are retained and encrypted, but also when the systems are communicating with each other. The clinic's sending system communicating HL7 messages, CDA documents, file resources to the receiving system, which is then transforming the entries. We're talking about encryption, talking about provenance in this case. These are all auditable steps. This is the Act 1, and the same is true also for the second act when there is a subsequent appointment for Adele for her second vaccination. You can see that Adele visits the web portal operated by the National Public Health Authority. She's able to identify herself. She requests a QR code, and then downloads her PDF to her phone. And for all these steps, you have digital signatures, you have encryption, authentication, and of course you have also the downloaded PDF, which then needs to be secured as well. This is just to give you an example of how the benefit of technical standards can be leveraged in the case of Adele's vaccination story. I hope I was brief and open to any questions and to this discussion. Thank you very much.
Thank you so much, Matthias. I think that gave a really good summary of Adele's journey, which we are finishing here. And as we are running out of time, I'm afraid we don't have time for question and answers, but I have seen that a lot of discussion has happened in the Q&A already. I would like to take the opportunity to really thank all the speakers and all the participants today to go with us on the vaccinations journey, which is important for all of us. I invite you really to stay engaged with JIC. You have seen that it's very important that and how we are cooperating and working together, and that it's of benefit for all of us. And with that, I hope that your vaccination has been happening already, is happening soon, and I wish that you all stay safe. Thank you so much for joining us today and hope to see you again. Thank you and goodbye.